there are no magic exercises that he's going to all of a sudden start doing that's going to help with his back pain. Back extensions or deadlifts or single leg toe touches on a Bosu ball with a special band hanging from the ceiling. There's no...
That sounds exciting.
There's no... And that's sort of liberating in my mind.
This is Generation Health. Every week we bring you the latest in news, cutting-edge research, and time-tested best practices helping you live a longer, healthier life. Sitting across from me, PharmD, Certified Strength and Conditioning Specialist, Dante DiMatteo. How are you, sir?
Not too bad, Tyler. Not too bad, hanging in there. How are you?
We'll talk about me in a minute. Sitting behind third mic, Josiah Schweinberg,
I'm
our
nervous
engineer.
for the grand reveal, yes.
There's nothing. I was right about to say your name, and Dante interrupted me.
I was trying to say how I was doing.
I'm less excited to be here now that there's not a...
I have a dog. She's fantastic. We've had her for a couple of weeks. That's about the only exciting thing in my life right now. Other than this, I'm excited about today's show.
Same.
Why are you excited, Dante? What are we talking about?
We got a few hot items on tap for today.
Yeah.
We have 2 listener questions. One is in reference to failed back surgery syndrome and NSAIDs.
Yeah.
And also best practices when taking different dietary supplements.
Cool. Okay. All right. First, let me share what's going on in the world of pharmacology, because there's always big news there. We actually missed this news earlier in the year. Bristol Myers Squibb, major manufacturer, has launched a variety of medicines into space aboard the SpaceX Dragon rocket. The mission was part of a commercial resupply for the International Space Station and continues research done by Bristol Myers Squibb in a previous launch back in 2020. Why are they launching their drugs into space? That's an excellent question, I ask myself. In microgravity conditions, the way different chemicals crystallize changes. For some, the crystals are larger and more well-ordered than on Earth. As one researcher said, quote, microgravity gives us higher resolution crystals that offer information we can leverage for designing new drugs. Bristol Myers Squibb hopes they will gain greater insight into complex molecules, improving biomanufacturing, and find ways to ease the delivery of high-dose therapeutic proteins. In specific, they are hoping for a way to reformulate infusion drugs like those used to treat cancer into simpler subcutaneous injections. That would be a really big deal if you could get your chemo just in a quick shot instead of having to sit there for hours.
Mm-hmm.
And then in a follow-up to a story we just talked about a couple weeks ago, major retail pharmacy giant CVS has pulled all of their over-the-counter cough and cold medications containing phenylephrine from their shelves. This follows on the heels of the FDA's advisory panel suggesting to the FDA that phenylephrine was not an effective oral decongestant. It is effective if you take it intranasally, but not orally, and CVS is preemptively pulling those from their shelves. The other giant in that world, Walgreens, is waiting until they hear the FDA's final ruling before they make any moves. Dante, now I have to ask, do you guys have other things on hand to help people out since phenylephrine is not apparently an effective over-the-counter medication?
We do. The cold and flu part of pharmacies are, there's a million options at any given point. So plenty of options, but there's plenty of combination medications, plenty of combination products that we still are carrying at this point. And so I would imagine over the coming days, weeks, months, years, that there's going to be a whole slew of reformulated combo products. So we'll probably do away with our combo products at some point, keep the stuff that's individual, the Sudafed, the guaifenesin, and the sort of the different medications, the antihistamines that work. And just, again, like I said, wait till we get the new and improved combos. That
was one of the things I thought was really interesting about this change is that while it's no good that the FDA took this long to come to these kind of conclusions, it is exciting because it will force researchers and manufacturers, hopefully, to look for more effective, better ways to treat cough and cold, because it hasn't been researched in any substantial way for decades because of the products that were on the market.
I don't expect anything major at this point to change. especially as these manufacturers are probably having to go crazy pivoting.
Yeah, retooling everything.
Yeah. But yeah, it'll just force pharmacies, pharmacists, technicians to recommend the big guns that we know work, the Benadryls, the Sudafeds, Mucinex, all the other sort of things. Tylenol by itself, ibuprofen by itself.
Just treating specific symptoms instead of, that makes sense, a combo product that's supposed to do everything, but you may not need all of those things.
Sure. Which there's no shortage of. So.
Right. Yeah.
So what were you going to say, Joseph?
Do we need to wait till SpaceX comes back with a new discovery of phenylephrine alternative or something?
Yeah, they got to send phenylephrine up to space.
Yeah. I don't know if it's going to work. Maybe in space it'll work orally. Who knows? I thought that was pretty cool that they're sending drugs into space.
CVS is sending all their old phenylephrine up into space.
That's not true. We're going to get sued. You can't say that. Oh, that is...
They might be. Where else are they going to do with it?
That's a good point.
You can't just throw it in the trash.
Might as well just throw it in space. All right. Eric emailed us a question. He emailed us questions@askjoedimatteo.com. That is where you can email us a question as well. If you have any, we would love to hear them. But Eric wanted to know, I'm currently taking 1,500 to 3,000 milligrams of Tylenol daily due to failed back surgery syndrome and would like to take something natural instead. Every brand claims they have the best, most highly absorbed and effective form. Is there really a better or best brand or formula? I'm a longtime customer from the Len and Joe days. Well, that's going back a ways. Thanks for keeping up the good work, Eric. Not thank you, Eric, but Eric is thanking us for keeping up the good work.
But thank you, Eric.
Thank you, Eric.
Thank you, Eric, for emailing. Yes.
All right. So what is failed back surgery syndrome? I've never even heard of this, and it sounds horrifying.
In the simplest sense, it's just persistent back pain after surgery. So it is a technical diagnosis.
Yeah.
More formally known as post-laminectomy syndrome, which is referring to a particular back surgery that is often done.
Okay.
And so it is a little legitimate and legitimate diagnosis. However, as you mentioned at the outset, it is a bit of a scary term.
Yeah.
And sometimes a diagnosis, seemingly innocuous, seemingly just whatever, it's just a label. It's just a diagnosis.
Right.
Usually when you think on it a little more, they carry more weight. And so something like failed back surgery syndrome, I can't imagine being happy with that label.
Yeah. I mean, back surgery in and of itself is such a scary concept. To have it fail sounds even worse. And then to have it fail in such a way that you consistently have back pain enough to take a large amount of Tylenol daily, that's a big deal.
Yeah. With some of the commentary here doesn't really apply to the way that Eric framed it.
Yeah.
But I thought it was very interesting that over the last several years, clinicians have tried to do away with that terminology.
Fair enough.
Just because it's not always the most accurate.
Right.
Again, it has that sort of failure stigma attached to it. And it doesn't really always help to clarify what the underlying issues are.
Okay.
And often there's not one underlying issue. So.
Right. Because it's a syndrome. So it's a set of symptoms.
Yes. But failed back surgery syndrome it doesn't really do much in, answering the following questions. Did the surgery simply fail to relieve the symptoms, which is
right. That's
probably
what it sounds like.
Right. Did the surgery exacerbate what symptoms already existed, or did the surgery itself cause new symptoms?
Wow.
And so with that, and again, I tend to do this, you kind of get caught up in terms. What's this actually saying? Where did this diagnosis come from?
Right.
Can a patient actually do anything with being told that that's their diagnosis?
Yeah.
So again, the clinicians are, in a good-hearted way trying to pivot away from that. So what they've suggested is a more broad term that just simply calls it persistent spinal pain syndrome.
Okay.
And so there's two types. And so it will include what we mentioned, did the surgery actually cause a new problem?
Right.
Did the surgery just not work that well? What were the expectations of the surgery? Did you really expect that this this surgery was going to be the one that got rid of every one of your back pain symptoms.
Right.
You know what I mean? So it just forces this new way of framing it can kind of help improve the mindset that the patient has. It can help improve the realistic expectations of a given procedure, and it can help better guide the treatment. Because if you're told that, hey, this back pain is caused by this surgery, we don't know if it was the back pain that caused your surgery. It might have been.
Right.
The individual is just going to say, well, unless I get another surgery, or if it wasn't for this surgeon that botched the surgery, seemingly, that, how are we going to move on from this? So not to get lost in that, not that Eric cared for my commentary around failed back surgery syndrome. I just think it can be helpful to understand where this stuff comes from.
So what's the new term?
The new term is persistent spinal pain syndrome.
Persistent spinal pain syndrome. PSPS.
PSPS. And there's type 1 and type 2.
Okay.
So
what's the other type you mentioned?
So type 1 is technically there was no surgery. Symptoms.
So it includes people who haven't had spinal surgery.
Right.
Okay.
Who diagnoses this?
I guess your doctor, after the surgery, if depending on how much time goes by and what the, sort of their metrics of outcomes that they're looking at, they can then say, hey, so-and-so post laminectomy syndrome or whatever. And then that kind of.
Well, you hear people with back pain all the time.
Right.
And you always advise people, don't go on WebMD and start typing all your symptoms, because then you'll get this diagnosis of
failed back surgery syndrome feels like one of those.
Yeah.
You start easy to start researching some things on your own.
Yeah. And you're
landing on that and then being
you're moments away
doomed
from being a quadriplegic because you read it on the internet. So, okay. So there's the two types. The type 1 is the one that doesn't involve any surgery at all. Type 2 is the one he's talking about where he had surgery and for whatever reason, he's got this persistent pain now.
Mm-hmm. Is it indirectly related to the surgery? Is it direct, indirectly or directly related to the surgery? It's just always very hard to say.
Is this it seems like this is a lot of acetaminophen. That's the active ingredient in Tylenol, right?
Mm-hmm.
1,500 to 3,000 milligrams per day, every single day, for 365 days a year. That seems like that would add up fast.
It sounds like a lot. The safe recommendations are anywhere from 3 to 3.25 grams per day.
Okay.
So 3,000 milligrams to 3,300 milligrams a day.
Oh, so he's still within the realm of safety.
Yeah.
Okay.
The old recommendation used to be 4. I don't even really know if it was an old recommendation. It's kind of just the do not exceed this amount. And it was always, at least I remember in school and working in a pharmacy before school, was always 4 grams. So 4,000 milligrams. So safely, you can say if you stay under that 3,000, 3,250-ish mark, that's a good place to keep in mind. But it's complicated because, Tylenol, acetaminophen, paracetamol, depending on where you're from, all describing the same product, just comes in a variety of combination products, like we mentioned with phenylephrine. It's in a variety of different dosing, liquids and capsules and tabsules and these different things. 325 milligrams, 500 milligrams, 650 milligrams. And then if you have a cold, you might be taking a combo product that has 325 milligrams. So
that's a good point.
So they feel that these are the sorts of reasons why it's so critical to hone in on this max dosing window, is because it's so abundant in over-the-counter products. It might even be in one of your medications. If you were on an opioid medication, sometimes that's paired with acetaminophen. And so it's hard for the average person to kind of keep track of all of that. And so I feel that's one of the most complicated parts of this.
That makes sense. And it makes sense as to why you would want to reduce that as much as possible so that you've got as much headroom as possible for when you have a cold or something else.
Mm-hmm. And on average, it's not that Tylenol is the most effective thing in the world.
Right.
I would say head to head versus using Tylenol for reducing a fever, that still seemingly works a little better than Tylenol for osteoarthritis, Tylenol for low back pain, Tylenol for, persistent spinal pain syndrome. It seems as though using it while you're sick, using it for a fever is a little better anyway. You have to have tempered expectations with how well Tylenol is really working to begin with.
Yeah.
So to push it beyond that maximum range, that's when you start to get into the conversation of really having to look at risks and benefits. You know, again, it's a seemingly innocuous product. It's in every single product over the counter.
Yeah.
You know, my doctor said I could take it, you know, the extra strength and the arthritis strength. I might as well just take it. You know, it's not without issues. It's certainly the lesser of evils when looking at many, you know, medications that have been used for similar issues. But again, there are still always costs associated with any sort of intervention like this. Not to scare him away from using it. I think what he's doing is generally fine.
Okay.
But we can expand upon some of this.
Right. So the purpose of NSAIDs in general is they're anti-inflammatory, right? So theoretically supposed to reduce inflammation, which will reduce pressure on nerves. Is that the idea? Okay.
I guess.
What is there, naturally speaking, if he's looking for a natural solution, what are some other natural options he would have to maybe take the place of some of this acetaminophen?
So the one that really comes to mind would be something like turmeric. And then even our Inflamove has turmeric. It has other sort of natural anti-inflammatories, if you will, that can help. Now, is it helping because it's lowering inflammation? That I guess we can try to assume that, but a lot of times inflammation is a good thing.
Sure. When there's an injury.
So this predisposition that we have to just say inflammation bad, let's do whatever we can to lower it. You know, it's not really my expertise either, but I sometimes hesitate to feed into that mindset that NSAIDs are working because I have inflammation in my spine and I'm lowering the inflammation and that's why it's working. It's more nuanced than that. Yes, by definition, that's what those drugs are doing. That's what those medications are doing. It's just, there's a little more to that conversation than really I can even expand upon. It's just that it is easy to be reductionist in that way.
Sure.
So turmeric, Inflamove, that can really help. The turmeric works a little bit more like an ibuprofen, a little more like the standard profile of an NSAID.
Okay.
But certainly at the doses that we have in those products and the doses that are recommended, we'll generally glean towards less of those issues. You know, you see GI bleeding and all sorts of cardiovascular risks implicated with long-term NSAID use that it seems like the turmerics and the white willow and those sort of products don't necessarily have. And even wanted to mention I know we kind of started getting into some of the downsides even with Tylenol. Yeah. Even though it's not an NSAID, there still is the risk of some of those GI issues. Maybe not to the extent that ibuprofen or naproxen carries, but there's plenty of evidence at this point to say that it's worth considering, especially as you exceed doses greater than like 2 or 3 grams a day for the long term. And then certainly it depends on, what's your history. Do you have a history of ulcers? Do you have a history of GI bleeds? Do you have a history of upper GI issues? All of those things matter. Do you have a history of also using ibuprofens? Are you using ibuprofen, are you using NSAIDs at the same time? So then there's a potentially additive effect of some of those GI issues. So at the end of the day, if you take 3 grams of Tylenol to manage low back pain and it's helping you function, then you can pretty much ignore a lot of what I'm saying. It's just that it's worth noticing how much color there is to these conversations.
Sure. And I'm glad you just said what you did, because it pointed out I constantly mischaracterize Tylenol as an NSAID. It's not an NSAID. What is it?
Believe it or not, the research just still shows that there's kind of an unclear, explicit mechanism understood for all of the ways that Tylenol actually works. So it works kind of like an NSAID.
But ibuprofen is the traditional NSAID.
Aspirin. ibuprofen, and naproxen, meloxicam, ketoprofen, all of those.
Okay.
So
I just need somebody to tell me what's safe and effective.
Yeah, there's a it's the cyclooxygenase pathway that the NSAIDs actually work to inhibit.
Okay.
So there's two pathways, and there are certain NSAIDs that are selective for one versus the other. There are certain NSAIDs, the early ones, that are selective for both, and they have maybe some more side effects. Tylenol sort of falls into this other category that, yes, it works to reduce the actions of some of those pathways or one of those pathways, but it's not doing it the same way that ibuprofen is.
Okay.
So it's still worth talking about in the same conversation.
Yeah.
It's just unfair to say that it's doing the same thing as what seemingly it's, brother and sister meds.
Got it. Okay. All right. So if he's looking to do something natural, turmeric, we've got turmeric matrix, I believe essentials is what it's called. And then you said Inflamove are the two big options. But in addition to that, there's the don't be afraid of the amount of Tylenol you're using right now, assuming everything else is normal. But certainly trying to move away from that over time is not a bad goal. What else can he look to do to mitigate this recurrent spinal pain?
Yeah, the $1 million question, I would say.
Yeah.
For so many people.
Other than getting more surgery.
There are many novel surgeries and minimally invasive surgeries at this point that seemingly do have some good evidence and good outcomes. And so it's not that those direct interventions are bad by any stretch, and not that they don't help tons and tons of people. It's just that, again, given Eric's situation, it seems as though there are other ways to approach this.
Yeah.
And so one of the ways that helps me look at a lot of this is just by hearing some different, just the way different physiotherapists, different PTs, different even orthopedic surgeons sort of talk about this. There's one PT in particular. His name is Greg Lamont. Greg Lehman. I don't know how he says it. But the analogy with pain in general, and especially low back pain, is, this analogy is seemingly exists for a lot of things in life, but you have to look at pain as if it's this cup. And so there's a lot of things that go into the cup that can be contributing to pain, and that when the cup eventually overflows, that's when these overt symptoms and all these negative experiences and things start to occur. And so what can go in that cup? There can be tissue damage, sure. There can be, disc sequestration. There could be disc herniation. There could be, a past spinal fusion. There could be an L5 issue. There could be whatever. There could be all these things physically happening. But then there's also your anxiety around the pain, your rumination about the pain, your past experiences with pain, family histories, interactions with surgeons, all these different things. What sort of activities are you currently doing? Not enough activity, too much activity. And so you see that by the time you factor in all those things, it's very hard to say, oh yeah, it's just one of these things that's causing the issues. Yes, it may have sort of stemmed from something that they found on imaging, that yes, it's not that the biomedical results it's not that they don't mean anything. It's just that those sort of findings always need to be taken into context. And so what Greg suggests is that you have to find ways to either make the cup bigger, or once the cup starts to overflow, how do you start to clear out some of those things that I mentioned? Right. And so by looking at his experience as best as he can in a holistic way, so maybe that's some Inflamove, maybe that is some Tylenol like he's already doing to keep moving. Maybe it's he finds a new physical therapist, somebody that's a little more forward thinking and isn't too caught up on certain, imaging and feeding into maybe the narrative that Eric's experiencing here. There's so much. And also knowing that in addition to the sort of the cup analogy, there are no magic exercises that he's going to all of a sudden start doing that's going to help with his back pain. There's not back extensions or deadlifts or single leg, toe touches on a Bosu ball with a special band hanging from the ceiling.
That sounds exciting.
There's no matter what anybody says,
right.
There's really nothing. And that's sort of liberating in my mind. There's not this, what you'll get out of a really good physical therapist are not the magical exercises that they have, but the sort of the combination of the art and science of, leveling with the person, understanding and factoring in these experiences around pain and emotions and anxieties and fear, and also having a biomedical understanding of, okay, it does look like there's something going on. There was something that maybe did occur at the disc. Maybe you did have 3 surgeries. It's not discounting that. Maybe it was a trauma. Maybe there was a car accident. Maybe there was something that led to this, but then combining all those things and then just adding in some graded exposure of movement.
Right.
So it's not the specific movement itself. It's just that finding tolerable levels of movement are what ultimately help start to move the needle with people. So if Eric really likes to run, it's not that you just let's start running. Well, maybe he can. Maybe he's ready to do that. Maybe it's walking. Maybe it's Greg Lehman mentioned running in a pool, or finding ways to run towards the things, no pun intended, that you like to do.
Yeah.
There's so much, there's ultimately so much to that. So graded exposures, and that looks different for a lot of people. That might mean, like I'm saying, doing more of the thing and trying to move closer to the thing that the person is unable to do that they want to do.
Right.
To start to instill some of that purpose again, and you got to do the things you like to do.
Yeah.
But then also there's nothing wrong with taking time off of the other thing and doing a bunch of other things. You know, the world is sort of your oyster, and that's what a good therapist can help you start to unpack. So I know that was a lot, but
I like that. You're talking about pain as or the cup, the capacity, and saying there's all kinds of things that go into that. And sometimes a lot of times tissue damage itself, which is what we always associate with pain, is not really the culprit, or at least it's not now the culprit. That stress and anxiety and fear and too much activity and too little activity and all those things go in there. And so if you could take some of that out, if you can start moving when you're not moving, or stop moving, stop doing the the warehouse work that is causing you to be sore at the end of the day, whatever it is, if you can change some of that, your attitude around the pain, that can all work together, along with having movement as a part of recovery for the purpose of moving toward what it is you want to do.
Yeah.
If you like fishing, you should be able to go fishing. And if that means you need to start exercising more, and maybe you need to take a little bit of Tylenol on the days that you go fishing, don't stop fishing because you're afraid of the Tylenol.
Right.
That the whole point is go back to life.
Right. That's a perfect way to summarize it, I would say. And the issue that sometimes people will have, or even maybe Eric is hearing us talk about this, well, what in the world do you guys know? I mean, you don't know how bad how much this has irritated me.
Right.
You don't understand the interactions that I have with my surgeon. I can send you my MRIs right now.
Yeah.
I can send you my X-rays. This is rough. And again, that's not the point. We're not saying that, what, Eric, it's all mental, man.
It's not suck it up.
You're just scared of hurting it. It's just that the flip side is also harmful by only looking at your X-ray and then being sort of bound by what that tells you as far as your, I forget what the term was. It was almost like you pause your life based. It's like a biographical pausation. So it's like you get this diagnosis, or you have this, MRI, and it shows that you might need another surgery, or this surgery didn't work. And so then you just put everything on pause until the next surgery or the next thing makes it better, so that you can go do the things. You almost have to just you have to press play now and start drifting towards the things that you mentioned that give you ultimately the purpose. The thing that I don't want to lose sight of is that there are also many instances where serious red flags, they call them in some of the literature and some of the guidelines, that red flags are missed. You know, somebody had a malignancy on their spine that just looked like and felt like a disc issue, or they were lifting too much too soon, or they are maybe a more fearful type and heightened pain. You know, it looks like all the things we're talking about, but in reality, it was something more serious. There was a neurological issue. There was some sort of vascular issue. Again, there was a tumor, malignancy, something that we don't want to lose sight of. And so those initial evaluations are to help sift through to ensure that that's not the issue.
Right.
You know, but then let's say you get past that stage and then you get into some of these yellow flags, they'll call it. And that's the things that we're talking about. It's maybe this, impaired coping around pain, impaired processing around pain and rumination and some other things. It's that once you get to that point and you roll out a lot of the red flag symptoms, and this has been going on for 4 weeks, 6 weeks, 8 weeks. Yeah. Yes, you still want to follow up, or this is something maybe that's been going on for a decade, sore knees, sore back, shoulders. You're at least in a position where you can say, look, it's there anyway. I need to start moving towards and using this holistic approach, using some Tylenol, using some Inflamove, using some different movements that don't aggravate me to move me towards running again, to move me towards fishing again, to move me towards these things. So everybody's timeline is a lot different. But again, if you're somebody who, in what I hear Eric saying, this has been bothering me for a decade. This has been killing me for a decade. I had 3 surgeries 5 years ago and this and that. It's like, okay, look, you're in a position where it seems as though they may have rolled out something that is a critical issue. Right. Now start, surround yourself with the right person, the right clinicians, do what you can, empower yourself and just start, rolling that ball.
It's almost as if to say, not to minimize his pain or the experience. At the same time, go, what's your other option? Do you just give up? You might be in substantial pain, but if your choice is be in substantial pain and stop living life, or be in substantial pain and live life, I know which one I would rather do. So that's a long-winded big way of saying, we've got some supplements that could help. Also, make sure you're doing your PT and don't wait forever to re-engage.
That would be my last takeaway. Anybody who has a black and white answer around this kind of stuff, I would run far, far away from that advice. Yeah, for sure.
If it's too simple, if it's too good to be true, it probably is. We've got another email, this one in from Joyce. Joyce emailed us at questions@askjoedimatteo.com. She said, I would like to know about supplements and when they should be taken. Should they be taken on an empty stomach or with food? How long should I wait to take digestive enzymes after taking supplements with a meal? Which supplements should be taken alone? I recently read that zinc should not be taken in combination with other supplements from another doctor. Is that true? Thanks, Joyce. Well, thank you, Joyce. So there's a lot there, but let me try and break this down as best we can. She was asking what supplements should be taken on an empty stomach versus with food. Are there clear delineations in that?
In general, yes. So there's fat-soluble vitamins. There's water-soluble vitamins. Fat-soluble vitamins are A, D, E, and K. Okay. And because they're lipid-soluble or fat-soluble, it might be worthwhile to take those with food that contain a fatty or lipid component. So peanut butter or fish or yogurt, avocado, nuts, some yogurt from fat-containing yogurt. Right.
All of my yogurt has fat. I don't know what we're talking about.
Anything like that can help. Now, as far as water-soluble goes, essentially you just don't have to worry about those kind of things. It's
so A, D, E, and K. So everything else,
pretty much everything else is going to
be C. Okay,
B's and C's are the ones that I think we're referring to here.
So those are the water-soluble ones, and those don't matter at all.
So I think that segues us into the next layer to this. Okay. So it's not that it doesn't matter; it's that you would be fine taking those on an empty stomach, but sometimes you're balancing the optimal absorption with, can I tolerate this? Does this upset my stomach? Does it give me indigestion?
That's right, because C can cause some people a lot of irritation.
It can. Okay. It can. So that is the big picture with this conversation is Joyce, we can go through every medication, every supplement, every combination, every disease state, every single thing that factors into optimal, we'll call it drug absorption and such. We had an entire course on it in pharmacy school, so it's not going to fit into a 10-minute discussion.
Sure.
But for the sake of answering her direct questions, it's a balancing act of, yes, you want to be optimal. You're paying a lot of money for supplements. You're paying a lot of money to do things the right way.
Yeah, you want them to work.
You might as well do what you can to bump something up from an 8.5 out of 10 to a 9 if you want, or a 7.5 to a 9. Yeah. So I get that. Now, in general, again, fat-soluble versus water-soluble, that's the broadest category. A lot of these are found in combination in
like a multivitamin.
Multivitamins. So you're like, okay, what do I do? Well, you're just balancing can I tolerate the multivitamin? Is this something that upset your stomach in the past? Is it whatever? If it doesn't, take it on an empty stomach, I guess. Or, it doesn't necessarily matter.
So for the most part, we're talking about kind of playing around the edges. This is not a critical thing for most of these supplements. Okay.
I took a multivitamin on an empty stomach once. I will never do it again.
Oh, yeah?
I don't know. It's like, I don't know.
Is it just a personal response thing, the way you respond? Yeah. Wow.
I think so.
Okay.
And then who knows? I mean, there's certainly a psychological component.
That's what I'm thinking.
Thereafter.
No, when I take my supplements, it's 100%. Heather makes fun of me all the time. Like with meals, I'm always taking it. Like today, I packed it up in my little Ziploc bag to have, but I'll have it right before, lunch or this afternoon. I don't think any of it.
Whatever works for you.
I appreciate that.
Yeah, I give you permission.
Our zinc immune complex, I took that as zinc, elderberry, and D3.
Okay.
I took that and it made me so sick in the morning.
Wow.
I took it on an empty stomach.
Maybe don't do that one. Yeah. She mentioned, that was another part of her question, was she read somewhere that zinc shouldn't be taken in combination with other supplements.
Yeah, and that's a great question. That's where a lot of this can get a little hairy. In a vacuum, it's like Joyce is just taking a few supplements. She has no underlying health issues. Sure. She has no, she doesn't follow this sort of dietary pattern and all this kind of stuff. You're assuming all conditions are met.
Yeah.
But as soon as somebody's on a thyroid medication, as soon as somebody's on a PPI, as soon as somebody is on, they take other antacids or they're on an antibiotic, ciprofloxacin, then it really complicates things.
Okay.
There's grapefruit juice, there's interactions with certain medications. Sure. So it's convenient to have this conversation in isolation, but the vast majority of people at this point might be taking levothyroxine in the morning. So how do you space that out in relation to your supplements? And then all of a sudden, when you're taking your supplements matter much less to, as compared to making sure that you take your thyroid medication,
right? Yeah,
for consistent absorption, which really matters, on a day in, day out sort of basis.
Yeah, yeah.
So with zinc, that would be one to take 1 to 2 hours after meals, I think is one of the stock recommendations. So yes, in theory, you're kind of separating it from other stuff, but most importantly, make sure that you at least have a feel for what your medication list is, and then make sure you also just continue to take what you're taking on a consistent basis as well.
Consistency is probably more important than the specific timing of a lot of these things. Talking about supplements, not medication. She had one other question there. She mentioned digestive enzymes, and that was, I had thought about digestive enzymes and probiotics because those specifically deal with the digestive tract. Do they have different recommendations as far as when to take them?
Yeah, those are relevant products to this discussion. So digestive enzymes, some say 30 minutes before you eat, 15 minutes before you eat, while, just right before you start eating, you can take the enzymes. So
like with first bite of food kind of thing.
Yeah. Yeah. Cause essentially if you space it out too far, you're going to kind of miss the opportunity of how they're supposed to work.
They're
supposed to help you digest the food. So if you think there's too much of a gap on the front end or the back end, what did they have the opportunity to do what they were supposed to do? So if somebody tells you like 5 minutes versus 8 minutes or 15 minutes, those getting lost in some of those nuances is rough.
Yeah,
I'm sure we could find some study of somebody's digestive product that it was optimal to take it 15 minutes before, 10 minutes before.
Right.
But that you might have to play around a little bit too with something like that. And then probiotics, I don't really think matter that much either. Okay. The big thing with probiotics, especially if you have some sort of GI issues, being consistent on a daily basis, to even to be compliant and take the the supplement is key. But most of what's out there, most of what we carry, they're encapsulated physically in such a way that by the time they get to where they're supposed to go, they're sort of resistant to the impact that foods and liquids and beverages and other things can kind of have. There's 20 strains of probiotic in our probiotic essential.
Right.
And I'm sure we could look up and find some sort of commentary on certain strains that can better withstand environments without food.
Right.
Certain pHs and certain acidities and different environments that they're most able to be viable, essentially. So,
but it's like a multivitamin in that it really, so long as you're tolerating it okay, it doesn't matter that much. It's designed to work in combination at the right time, whenever that is.
Sure.
So consistency is more important than timing on that as well.
Yeah.
Okay.
Yeah. And then some of the obvious stuff, stuff for sleep.
Yeah.
Taking it towards bedtime, melatonin, magnesium.
Yeah.
Magnesium, that's one you might want to have a little food in your stomach as well. Not really critical one way or the other.
Dude, one morning, I meant to take our mood essentials. We have mood essentials. I meant to take it before I came in to work, and I saw I accidentally took our essential sleep. I grabbed it real quick before I left. I wasn't thinking. I was like, Dragon, I saw your dad. I saw Senior. And I was like, man, I accidentally took, he made fun of me the rest of the day. That was terrible.
So take your sleep essentials at bedtime.
Yes, not in the morning.
And your mood essentials in the morning.
What a goof.
There was another one that came to mind. Iron is used a ton.
Yes.
And so there are other interactions with medications, of course. And so oftentimes it's recommended to separate it by at least 2 hours from other medications and other things. But iron is another one that can upset stomach, cause some GI issues. So you're still balancing the efficacy with the tolerability.
Right.
You know? And so,
because if you can't tolerate it and you stop taking it, then it's definitely not going to be effective.
Right. So that's something you want to take on an empty stomach. But if it bothers you, then you might have to take it with a little bit of food. That's something that absorption can also be enhanced a little bit by taking it with vitamin C. Sometimes products have it together. Anemia Essentials has some vitamin C in there.
Yeah.
Some people take it with a little bit of orange juice. It's just a little thing, more or less. But,
all right.
But yeah.
So fair enough. That's a fairly comprehensive answer there. I hope that helped. Joyce, there's a lot of answers, but the big ones, A, D, E, and K, don't matter at all.
Those are fat-soluble.
Those are the fat-soluble ones.
Take those with food.
B and C are the ones that don't matter. Mm-hmm. And then digestive essentials, and then something like the anemia essentials or iron or any of those others that might have zinc, that might have some impact on medication. It can kind of be a case-by-case basis, and you just want to double check. But read the label. It should tell you on there if there's a specific recommendation.
Yeah, and even calcium. I mean, there's so many. Even if you have osteoporosis or you're taking extra calcium, there are certain things where if you're on other medications, you'll want to separate it.
So just check with a pharmacist.
Definitely.
Got it. Very good. Very good. All of our products are available on our website. That is askjoedimatteo.com, askjoedimatteo.com. You can sign up for our newsletter, keep up to date on happenings on this show, on the original show, the Ask Joe DiMatteo show. You can find out about sales, anything that's going on. We talk about it on the email newsletter. The website there, askjoedimatteo.com. If you have a question, we want to hear about it. Email us, questions@askjoedimatteo.com. Show notes are going to be available down below. And if you learned anything, or you enjoyed this, or you know someone else who should be listening to this, please give the show a thumbs up, a 5-star rating, write a review, send it to somebody else. Sharing this show is how we grow. please, please, please let people know about it. Thank you so much to Josiah, our engineer back there. Thank you so much. Michael Deppish, our editor, who does not get enough credit. Joyce Gibb, our nurse practitioner, handles private consultations. Diane Silverman manages product. Terry does scheduling. Cecilia does distribution. That's Dante DiMatteo over there. I'm Tyler Andrews. Thank you so much, guys. We'll see you next week.